Hello, everyone. My name is Jean-Luc Urbain. I'm the current president of the World Federation of Nuclear Medicine and Biology and the chief and medical director of the Nuclear Medicine program at Wake Forest University in North Carolina in the United States. I've been practicing nuclear medicine for more than 3 decades, and I believe that there has never been a better time to be part of the nuclear journey. Over the next 20-25 minutes, I'm pleased to share with you some current and exciting future application in cardiac theranostics. The word theranostics stems from the contraction of the words therapy and diagnostics. It was first coined in 1998 in the pharmaceutical industry to describe a combined diagnostic and therapeutic approach for patient management. One of the many outcomes of the Human Genome Project has been the identification of the oncogenotype and oncophenotype of tumors. Current nuclear theranostic takes advantage of the overexpression of receptors at the surface of cancer cells. Using radiolabel specific ligands to these receptors enable to identify specific targets, quantify the tumor burden, and when labeled with a killer isotope, to destroy the cancer cells. But the concept of theranostic also applies to different diseases and different approaches in patient management. For example, we can use the biomarker approach, the imaging guided, and the biomarker imaging approaches combined that determine the steps in patient management. And in fact, nuclear theranostics, as we understand it today, probably represent no more than 10% of the overall concept of theranostics. In the next few slides, I would like to illustrate the potential of the concept of theranostic in nuclear cardiovascular imaging. Let us first look at cardiac infiltrative diseases. Pyrophosphate is an ubiquitous metabolic byproduct of many intracellular processes found in most mammalian cells. And of course, it can also be produced chemically. Pyrophosphate acts as a potent inhibitor of calcification. It antagonizes the ability of inorganic phosphate to crystallize with calcium to form hydroxyapatite crystal. By occupying some of the inorganic phosphate sites on the surface of nascent growing hydroxyapatite crystal. Part of the healing process of some of the injuries to organs is the ability to form hydroxyapatite crystal and generate calcification. Technetium-99m pyrophosphate bind to calcium that is liberated by the injured cardiac cells in myocardial infarction, as it is illustrated here on this research study in Dock from 1975. And as you can see on this slide, control subjects with no infarction do not have any significant pyrophosphate uptake, creating an infarct to the inferior wall and to the anterior wall clearly show pyrophosphate labeled with technetium-99m uptake. In 1982 already, Weisenberg and colleagues first reported that technetium-99m pyrophosphate imaging may be positive in cardiac amyloidosis. And this figure is taken from their original paper. In their report, Weisenberg showed that in 10 patients with cardiac amyloidosis, there was significant pyrophosphate uptake at the level of the left ventricle. Clinicians have known about amyloidosis for several decades. In fact, amyloidosis was first described in 1639. Amyloidosis is a group of diseases in which abnormal proteins, known as amyloid fibrils, build up in tissue. The symptoms depend on the type of fibrils, and they are often variable. There are about 30 different types of amyloidosis, each due to a specific protein misfolding. Some are of genetic origin, while others are acquired diseases. Cardiac amyloidosis is a form of restrictive infiltrative cardiomyopathy that confers significant mortality. The diagnosis of cardiac amyloidosis is challenging due to the relative rarity of the disease, the clinical overlap with more common diseases that result in thickening of the myocardium, like hypertension, chronic renal failure, hypertrophic cardiomyopathy, aortic stenosis. But it's also difficult because of the unfamiliarity with the proper diagnostic algorithm and a perceived lack of definitive treatment. There are two major types of amyloidosis that affect the heart. Light chain amyloidosis refers to a situation in which plasma cells produce monoclonal light chain antibody that misfold. In transthyretin amyloidosis, a point mutation in the transthyretin gene leads to the misfolding and dissociation of a protein into monomers. In both situations, oligomers, protofilaments, and mature amyloid fibrils deposit in the myocardium. Once used to diagnose myocardial infarction, technetium-99 and pyrophosphate imaging is now reborn as an alternative to biopsy for diagnosing cardiac transthyretin amyloidosis in patients. This slide shows two cases of cardiac amyloid disease which were referred to us by the Department of Cardiology for the assessment of cardiac failure in these patients. On the left side of the slide and at the top, you see that after administration of pyrophosphate, there is clearly uptake of the tracer at the level of what appears to be the heart. This is confirmed by the SPECT-CT images showing significant uptake at the level of the left ventricular wall. This patient has a level 3 uptake at the level of the planar images, and the heart to contralateral ratio was about 2.5, confirming the diagnosis of cardiac transthyretin amyloid disease. On the right side of the slide and on the planar images, you can tell that there is a mild increased pyrophosphate uptake at the level of the heart. But the SPECT images demonstrate that in fact the uptake that we see is at the level of the left and right ventricular cavities. This patient had actually a case of light chain amyloid disease. And as you know, when you do a semi-quantitative evaluations of the heart to contralateral ratio, a ratio of more than 1.5 is highly suggestive of transthyretin cardiac amyloid disease, while patient with light change cardiac amyloid diseases ratio is most of the time, if not all the time, below 1.5. This is important, and the reason is shown on the next slide. The importance of the determination of pyrophosphate uptake in the heart is illustrated on this slide, showing that patients with a ratio of 1.6 or greater have a significantly poorer 5-year survival than those with smaller ratio. So it is important to give this type of information to your colleague in cardiology. The game changer in ATTR cardiac amyloid is that disease progression can be slowed down or prevented by novel TTR targeted therapies. Inotersen and patisiran are TTR RSNA silencing agents that prevent the hepatic production of TTR protein. Inotersen is an antisense oligonucleotide, and patisiran is a SMILE interfering RNA molecule. Both agents have been studied in phase 3 clinical trial involving ambulatory patients with ATTR cardiac disease and polyneuropathy symptoms. Tafamidis is an oral TTR stabilizer that binds to TTR tetramers in circulation and prevent their breakdown into unstable amyloidogenic monomers. In the transthyretin cardiomyopathy clinical trials, over 30 months, tafamidis was associated with a 32% reduction in mortality and a 30% reduction in cardiovascular hospitalization. Another example of the usefulness of nuclear cardiology is in cardiac sarcoidosis disease. While it is believed to involve the heart in up to 20 to 30% of patients with systemic disease, in fact, the heart may be the only organ involved in sarcoidosis. Sarcoidosis can involve almost any cardiac structure, but the left ventricular myocardium, particularly the septum, is the site which is most frequently involved. In advanced cases, the inflammatory process generates scar tissues, and aneurysm might result of the necrosis fibrotic process. Currently, the diagnosis of cardiac sarcoidosis relies on the comparison between myocardial perfusion and myocardial FDG images, where the FDG uptake reflects the inflammatory process at the level of the cardiac muscle. This slide illustrates the importance of having a sensitive and accurate test to diagnose the disease. As you can see on the left side of the slide, the baseline images demonstrate the heart, and there is also abdominal disease. After treatment, the uptake at the level of the heart is even higher than before the treatment, clearly showing that this patient did not respond to treatment at all. In contrast, this patient has extensive disease in the chest and the abdomen and at the level of the heart, as you can see on the baseline images. After treatment, there is a remarkable improvement with practically no significant FDG uptake at the level of the chest, the abdomen, and the heart, showing the successful response to therapy. In sarcoid disease, having a sensitive and specific tool to diagnose the disease and to follow up the disease and assess the efficacy of treatment is critical. The most exciting perspective in cardiac diagnostics lays in the availability of new radiopharmaceuticals that enable to evaluate the pathophysiology of cardiac ailments, essentially by labeling receptor at the level of cardiac and vascular cells. It is well known that chronic heart failure is associated with neurohormonal activation and alteration in autonomic control. In addition to the catecholamines actions and the development of interstitial myocardial fibrosis, the myocardial renin-angiotensin system has been closely related to the abnormal cellular and molecular alteration that parallel the left ventricle remodeling. Left ventricular remodeling, defined clinically as alteration in volume, shape, and/or function of the heart chambers in response to chronically elevated loading condition, has been appreciated as a central determinant of the clinical course and outcome of systolic heart failure. The identification and characterization of the renin-angiotensin system with molecular imaging in the individual heart failure patient is highly desirable in order to provide more precise information to predict and monitor the myocardial response to medical renin-angiotensin system blockade. It is also critical in order to fine-tune the treatment of these patients with heart failure. Although still in a research domain, the renin-angiotensin converting enzyme protein and the angiotensin type 2 subtype 1 receptor that are expressed at the surface of myocytes can now be imaged with PET and SPECT radiopharmaceutical. This slide shows the PET and SPECT radiopharmaceutical that have been used to label these proteins at the surface of myocytes. The imaging of the angiotensin type 2 receptor is shown on this slide in a normal pig model on the left side with a nice visualization of the left ventricle, and in a pig with myocardial infarction on the right, showing the CT delayed enhancement of the infarcted myocardium, the defect of perfusion in the anterior wall, and the visualization of the angiotensin type 2 receptor to the superior aspect of the anterior wall. As you know, the myocardium is a highly organized structure that contains several cell types, such as cardiomyocytes, fibroblasts, and endothelial cells, but also vascular and neuronal networks. Interspersed between these elements, the interstitium comprises a complex cellular matrix. Wound healing after myocardial infarction entails a cascade of events that involves a complex interplay between several different cell types, including inflammatory cells, endothelial cells, fibroblasts, and myofibroblasts. Myofibroblasts have characteristics of fibroblasts and smooth muscle cells. They produce extracellular matrix and are able to contract. In so doing, they can contribute to tissue replacement and interstitial fibrosis following cardiac injury. The balance between the synthesis and degradation of collagen during cardiac remodeling determine its turnover, and in the post-injury states, this process is regulated predominantly by myofibroblasts. Adequately healed infarct show preserved geometry, while inadequately healed infarct, in other words, with few myofibroblasts, show severe dilation and infarct expansion. Differentiated myofibroblasts express several targets that might be of interest for molecular imaging. The ATR, FRIS2, and TGF-beta receptor are reasonable candidates and easily accessible to targeting tracer molecules because of their extracellular localization. Additionally, the alpha V beta 3 integrins are expressed in the focal adhesion area and might constitute yet another candidate. The specificity and efficacy of these targets needs to be determined because, in fact, most of the targets are present on also other cell types. But nevertheless, they give the ability to researcher to image and quantify myofibroblast activity in infarcted areas. The imaging of the apoptotic pathway in myocytes in end-stage heart failure and in ischemic heart disease is a very desirable tool to have. Clinical imaging of myocardial infarction and myocardial apoptosis has clinically been evaluated by indium 111 label annexin 5, an endogenous protein that targets abundant surface exposure of phosphatidylserine residue. The yellow arrows on the images of the left side of this slide show the localizations of the myocardial infarction anteroseptal and anterior, and the significant uptake of annexin 5. What about vascular theranostics? Well, annexin 5 can also be used to document the instability of some plaque where there is an activation of the apoptotic process. On this slide, on the top left, you can see a significant uptake of annexin 5 in this patient with a carotid stenosis with plaque instability. In contrast, in the lower left portion of the slides, there is no significant annexin 5 uptake in this patient who also had a carotid stenosis. Having the ability to image and document the instability of a carotid plaque is invaluable because it helps the neurologist and the neurosurgeon to decide on the emergency of performing a vascular procedure when the plaque is unstable in order to avoid a stroke in patient. There is no significant research in Theranostic for the treatment and management of atherosclerotic plaques. As you know, atherosclerosis, which is a progressive condition characterized by the buildup of plaque due to the accumulation of low-density lipoprotein and fibrous substances in the damaged artery, is the major underlying pathology of most cardiovascular diseases. There are a number of potential cells and receptors involved in atherosclerosis, as pictured on this slide, that can be used for theranostic agent targeting, such as macrophages receptor, integrin AMB3 and VCAM1 receptors. Among these targets, macrophages are certainly the most commonly studied and used target because of its pathogenic role, phagocytic property, and abundance in the atherosclerotic lesions. Beside FDG, which is commonly used, there are now a few other tracers that are being developed to image the inflammatory process and instability of atherosclerotic plaques. Lastly, I would like to mention that the monocyte chemoattractant protein, chemokine receptor 2 axis, play an important role in abdominal aortic aneurysm pathogenesis, with effects on disease progression and anatomic stability. In this study, the authors assessed the expression of the chemokine receptor 2 receptor in a rodent model and human tissue using a targeted positron emission tomography radiotracer. They concluded that the imaging of the chemokine receptor type 2 can in fact predict the pending rupture of the abdominal aortic aneurysm. I would hope that through these slides, I was able to illustrate the current and enormous potential role that cardiovascular theranostic will play in the future of nuclear medicine. Thank you for your attention.